Welcome to the CCS class of acute myocardial infarction. So this is a very normal scenario that you keep seeing in your ICUs in your training.
Yes.
So what has happened here is that we have a 58-year-old male who came to the emergency department with severe chest pain radiating to left arm and jaw with diaphoresis and nausea. Pain started an hour ago, and he has history of hypertension and type 2 diabetes mellitus, and he does smoke. On presentation, his vitals are 90/50 is the blood pressure, the heart rate is 110, he's breathing at 24 per minute, and his saturation is 94% on room air. We did an ECG, and ECG shows ST elevations in 1 to 4. And there are elevated cardiac enzymes. The renal function is normal, and the blood sugar is 180. So, Dr. Stany, I would like you to tell me the diagnosis.
Well, I see two. I see the. I think this is an anterior myocardial infarction. Anteroseptal myocardial infarction. Yes, because yes. I also see the ST depression and in 2, 3, and AVF. So this is the reciprocal ST depression. So I think this is ST elevation myocardial infarction anteroseptal.
Great. So this is acute anterior wall myocardial infarction, STEMI. Okay, fine. So what next? So this patient has landed up in the emergency room and you are there. The patient is saying, do something, doctor. I am dying. Do something. So what you gonna do?
Also I think I do ABC A airway. I think it's stable because the patient can speak to me. Breathing. I think this set how much the SpO2. I probably take oxygen supplementation to get the SpO2 over 39. At 93, I mean 93%. Yeah.
95.
95. Okay. 95%. And C for the circulation, is the BP all right?
So what is the BP? Let's go back. The BP is?
Yeah, the BP is 90 to 50. It's in shock because the heart rate is higher than the BP. I think for the pain, I can manage with nitroglycerin, and if it's not working, I give him some morphine.
Okay. So what you've done is you've given oxygen, you've given morphine.
Or nitro, yes.
Plus nitro. As of now, this is what you've done, right?
Yes.
Is there anything else that you needed to do even, while you were doing these things along with that?
Yeah. Yes, I get IV access, and then I get blood. I send in blood work, as a CBC, kidney, and liver, and coagulation, and
wait. So this is basically interior wall STEMI, and time is muscle. Time is
I mean, I also call, of course, the Hertz catheter, of course, for the coronary angiogram, PTCA, and
even before that you give DAPT. What is DAPT? DAPT is dual antiplatelet therapy. So we don't need an IV access for that. We just give them 300 milligrams of aspirin
Yes.
Plus we give 300 milligrams of clopidogrel.
Okay.
Plus we give 80 milligrams of atorvastatin. Plus we give them injection low molecular weight heparin, 1 milligram per kg body weight.
Okay.
So this is the thing that you need to do immediately.
Okay.
And at the same time, give them NTG, morphine, and oxygen, as rightly you said, and activate the cath lab.
Yeah.
Yeah. So this is the order of things in which you do this. So you do an ABC quickly. Along with that, once you have the ECG in your hand, you cannot waste time. You need to load them up with antiplatelets and give them a shot of low molecular weight heparin like this.
Okay.
After that, you give them oxygen.
Do I need also to give them heparin 5,000?
See, if you are giving them low molecular weight heparin, then you don't need to give them IV heparin unfractionated. So either unfractionated heparin or low molecular weight heparin, either way.
Okay.
Either of them. You cannot give both of them because anyways, once the patient lands up in the cath lab, they are going to give IV heparin. They are going to give. Okay. Yeah. So this patient, as you rightly identified, has STEMI, and we have given them aspirin and clopidogrel and nitroglycerin, unfractionated heparin, or this low molecular weight heparin, oxygenation to keep the saturation above 95, IV morphine, and of course, prepare the patient for a primary percutaneous intervention. So what is the door to balloon time?
90
door to
minutes.
Balloon, 90 minutes for a PCI hospital. In case it is not a PCI hospital, then
120.
So it is 120 minutes. Wonderful. Wonderful. All right. So this is the angiogram that we did, and we found out that the left anterior descending artery was occluded here. Okay. So the balloon angioplasty was done, and a drug eluting stent was placed. We got a TIMI flow grade 3, and we shifted the patient to coronary care unit on ECG monitoring, blood pressure surveillance, and just monitoring overnight.
Okay.
Okay. So once we shifted the patient to coronary care unit, a couple of hours later, the nursing staff calls up and tells me that the blood pressure has dropped down to 70/40. Heart rate has gone up to 130. The patient has become cold, clammy, irritable, confused. And on auscultation, there is pulmonary edema with bilateral crepitations. The urine output has dropped to 10 ml per hour. We did an echocardiogram on the bedside, and we found out that there is severe LV dysfunction, 25%, and there is anterior wall akinesia. So what does this mean, akinesia?
It's not moving.
It's not moving. Wonderful. So what does this imply for the patient?
Infection, a big infection, anterior infection.
So the infarction means the area is dead now.
Yeah.
There is no hope. The area is dead. This is not going to get better even after, although we have done the primary PCI within 90 minutes. Still, the infarction was so major that the area has become infarcted, and the left ventricular function has dropped down to only 25%. You put in a Swan-Ganz catheter, you find that there is a low cardiac output. Pulmonary capillary wedge pressure is elevated, CVP is elevated, and the patient now has what kind of another diagnosis?
Cardiogenic shock.
So this patient now has a cardiogenic shock.
Yeah.
So how do you manage cardiogenic shock, Dr. Stany?
Can I see the other slides again? It's do I need to start I don't know the SpO2, but if he so if the patient had already cardiogenic shock with pulmonary edema, probably I can start non-invasive ventilation.
Wonderful. So step number 1 is patient should be put on non-invasive ventilation.
Yeah.
What
Step
else?
number 2, I give Lasix or as diuretics, probably 80 milligram Lasix.
Can you give it at a blood pressure of 70 by 40?
No, I cannot. I cannot give
So the patient will collapse.
Yeah.
We don't want him to die, right?
Yeah.
So what will we do?
Then I start Aterenol, noradrenaline.
Okay, so we start the patient on noradrenaline.
Yes.
To increase the blood pressure.
Yeah.
Okay, fine. So we started the patient on noradrenaline. Do we add anything else along with?
If he, I don't know. I think we need monitoring as a like a PICO as a transpulmonary. So we have Swan scans, right? So to increase the cardiac output, we need probably dobutamine.
Yeah. So we need this cold clammy skin. There is oliguria. There is signs of low cardiac output. To increase the cardiac output, we add the patient on
dobutamine.
Perfect. Now the pressure has increased to 110 by 60 on arterial blood pressure. Now what will you do? Now you give what you wanted to give earlier.
Yeah, the Lasix. Yeah, Lasix 80 milligrams.
So now you give Lasix 80 milligrams intravenous. Perfect. So you've given this patient noradrenaline. You've given this patient dobutamine. You've given this patient Lasix along with non-invasive ventilation. And now you do a ABG. Arterial blood gas to look for
lactate, pH. Yeah.
Lactates, pH, oxygen, all these things.
Yeah.
Okay, so this patient has cardiogenic shock, and now by definition, it is systolic blood pressure less than 90, end organ hyperperfusion signs should be there, cold extremities, confusion, oliguria less than 30 ml per hour, lactates more than 2, and cardiac index less than 2.2. These define cardiogenic shock. Phenotyping is out of the context. Identifying the cause is important. This patient of ours have acute myocardial infarction. He never had a cardiac arrest, but these are the other causes of cardiogenic shock. You can get different vignettes based on these: patient of cardiac arrest, ventricular, supraventricular arrhythmia, conduction disorders like complete heart block, infectious diseases like myocarditis, iatrogenesis like post coronary intervention, uh, coronary dissection, and of course, non compliance in patients who have been known to have a long standing congestive heart failure. These are the labs and investigations that we need to do. We need to do an ECG, an X-ray, laboratory tests, ABG, an echocardiogram, lung and pleural ultrasound. And maybe if you consider these patients to have coexisting aortic or pulmonary diseases, you might need to go for a CT scan. Considering invasive monitoring is very important. You need a CVP, you need an arterial blood pressure monitoring, you need a pulmonary artery catheter, and of course, you might need a IABP for the management. We will go for it. All right, so managing cardiogenic shock, we've already done that. You decided on the right lines that I will give the patient some dobutamine, some norepinephrine. I'll try to keep the blood pressure mean arterial pressure more than
65.
65. So we would like to keep the blood pressure, mean arterial pressure more than 65. And of course, we will manage this patient with the help of an invasive arterial line and a Swan GANs for cardiac output monitoring. So this is basically managing a patient of cardiogenic shock based on the gross presentation. So etiological therapy we've already done in this patient. This patient had a coronary artery disease and acute anterior wall MI, STEMI. We've done the reperfusion, and now we are managing this patient on norepinephrine, on diuretics, on NIV, and there is no sepsis. Okay. Now we define the patient on the basis of RV failure primarily or LV failure. So if it is an RV failure and we feel that the filling is inadequate, we give patient IV fluids. That is typically seen in inferior wall MI. Okay, so RVMI,
Yes.
we load them up with more fluids. We try to keep their filling pressures high so that they can maintain their cardiac outputs. And in case of a left ventricular failure, we need them to decrease the peripheral vascular resistance. We need inodilators. Drugs are dobutamine, milrinone, and levosimendan. Managing heart rate is also very important. We don't want these patients to stay at a heart rate of more than 100. But if the heart rate is low, we can use temporary pacemaker and, of course, isoprenaline to increase the heart rate to 100. Why? Because heart rate is an inherent component of cardiac output. Cardiac output is stroke volume into heart rate. So,
Yes.
so
Yeah.
if the stroke volume is adequate and the cardiac output is low, then all you need to do is build up on the heart rate. So you don't want these patients who have a low stroke volume to bring their heart rate down. You need their heart rate along with. In case the patient has a anterior wall MI with complete heart block, that means there is an ischemia to the His bundle and the conduction system. These patients, they don't do very well. They may develop a ventricular septal rupture later on, but they will require a temporary pacing lead to keep the heart rate afloat for the cardiac output to be there. Of course, managing other organ dysfunctions like hypoxia, ischemic encephalopathy, renal dysfunction, all of them are important and they are a side leg while we are managing the patient for cardiogenic shock. Okay. So you have given this patient norepinephrine, dobutamine, Lasix, non-invasive ventilation. You are monitoring the patient on pulmonary capillary wedge pressure, but still the patient remains hypotensive again. He's only 80/50 on maximal doses of norepinephrine and a good dose of dobutamine. Lactates are worsening, oliguria is not improving. What do we have here? What kind of a diagnosis this is? So we have STEMI, this is one.
Yeah.
Status post PCI, status post PCI is 2. Third is cardiogenic shock with acute kidney injury at the moment.
Yes.
So
I think this is a refractory cardiogenic shock because it's not improving with.
Yes. So by definition, this is defined as refractory cardiogenic shock. So this patient has a refractory cardiogenic shock. Very well picked. What do we do next?
We can start with intra-aortic balloon pump if we have one, but if we don't have one, then probably VA ECMO, PA ECMO, or send them back to cardiologist to do the impeller.
So we put this patient on the patient. So this is exactly how you do it. You are absolutely correct. But then we need to classify these patients on the basis of whether they will do good or not. So first is to define the refractory cardiogenic shock, or also known as therapy refractory cardiogenic shock. That is when the optimal fluid, inotrope, and pressure management has been done, but the patient still continues to have persistent hypotension with rising lactates and low venous saturations, and of course, signs and symptoms of end organ hypoperfusion. If the patient has had an active CPR or required a pharmacological resuscitation, then it is very important to see if the patient has neurological status. If the patient remains neurologically fit, only then we go for screening. This screening is important because these are the patients who, by ethical understanding, should not be offered any mechanical devices like advancing age, active malignancy, severe COPD, patients on chronic dialysis who have septicemia, other non-cardiac life-limiting diseases like ICH. Sometimes these patients, they have intracerebral hemorrhages, cachexia, frailty, poor health compliance, and these things. If they are present, then all we suggest is a palliative care. If they have intermediate presence of these things, then maybe a temporary VAD may be given for them for if they can afford. But then if none of them are there, then this patient definitely needs to be offered either an implantable LVAD, either as soon as possible or within next 24 hours. You can keep the patient on ECMO until then. So this ECMO will give you those 24 hours for the impella to come. So if this patient does not have any of these features of advancing age, malignancy, COPD, dialysis, sepsis, then you should definitely consider ECMO in these patients. Intra-aortic balloon pump, definitely that is very handy, but unfortunately, none of the literature, none of the trials have shown that intra-aortic balloon pump, if it helps with the survival. Okay. And as already we have seen, this patient has an akinetic anterior wall. So akinetic anterior wall means that unless we optimize this patient to such a low systemic vascular resistance, this patient is never going to come out of the IABP. Never. Because IABP will just reduce the peripheral vascular resistance. And if this patient does not get urine output, because this patient's urine output is dropping, and we know that intra-aortic balloon pump is placed in the aorta, and there are chances that it may occlude the bilateral renal arteries.
Yes. Okay.
Yeah. So this patient does not become a good candidate for IABP to be inserted. So this patient will require ECMO. So fine, as you suggest, we take this patient up for a VA ECMO.
Yeah.
We go by you, like you say. So we've done that. We put the patient on an ECMO. But the thing is, this patient has a akinetic LAD territory and the EF is only 25%. And we don't really know that we will be able to wean off this patient from ECMO also. And the patient has renal shutdown. So we have only 48 hours to our behest. If the patient does improve, fine. If the patient does not improve, then we have a problem. Okay, so we have initiated ECMO. We used femoral artery, femoral vein for the peripheral VA ECMO. The patient was flow adjusted to maintain the cardiac output, oxygenation, and perfusion. We tried to achieve everything, but at the end of 48 hours, the patient shows no significant improvement. The patient still continues to be dependent. The patient is on ventilator. The patient's urine output is not there. The blood pressure is low. We have decided to put the patient on a CRRT. What next? He's a young patient. He's just 54.
Yeah, probably send them to heart center for assist device.
Fine.
Left assist.
Let us say you are the heart center already.
Oh, okay. Yeah. Then send them to surgeon because we need probably left assist device, left ventricular assist device.
So we need, as you correctly say, a left ventricular assist device. Why do we need it? We need it as a bridge to decision. See, now good devices are also there. Impella with a good cardiac output can be kept for many years also, as they say. But then as of now, it is a bridge to decision. So we plan that we are going to put a LVAD as an indication because this patient, we are planning to transplant his heart in coming time. Now, what do we need to monitor once the, LVAD has been put. Now this is the heart and this is the LVAD put here. This is the power cord coming out. He's an Iron Man now. And the heart is pumping out blood. So what are the complications this patient can develop immediate post LVAD? One of the important complications is right heart failure.
The RV failure, yes.
Why does it happen?
Why does it happen?
Yes.
Because the RV function is depends on the LV function. If the LV function is very poor, then probably the RV function is also bad.
Okay. So I will help you out with this.
Okay.
Basically, our organ systems, they are all dependent on a pulsatile blood flow. Do you know, if some patient has an LVAD inside, you cannot really have their pulse because
Yeah,
you
we don't have a pulsation. Yes.
yes, we don't have a pulse. But if you talk of the right ventricle, it is still beating under the edges of SA node, AV node, his bundle, kicking
Yes.
the yeah, because LV definitely will give up on the impella or the LVAD. It will just not contract enough. But the RV is healthy, it will be contracting. So the thing is, the RV is wanting to give the blood to the pulmonary circulation and thereafter to the left ventricle. But left ventricle is beating not in the rhythm with our right ventricle.
Okay. Yes.
Yeah. So because that is a motor which beats, which is like uh, pumping out at, let us say, 2.5 liters per minute, like
Yes.
this.
Okay.
But the right ventricle is beating like 70, 80, 100, 110, 120, what at the most, how fast it can beat. So they can never meet each other. It is like comparing a man running on feet and somebody going on a motorcycle. So
Okay.
the RV is definitely hell bent to go into failure immediately until it gets used to the circulatory changes. Because we did not tell RV that we are going to do this to the LV. So RV suddenly feels, oh, what's wrong? What's gone wrong? I'm trying to give blood, but then this blood is I feel that it is only gurgling inside the lungs. It is not pumping. It is just, I'm pumping into something which is not taking it as a pump, it is taking as a motor. So that is how right ventricular failure happens, and that takes around 2 to 3 days to settle with the help of diuretics, decreasing the preload. Gradually, RV falls into place. Okay, so this patient, we went for RV placement and we managed the RV support. We required a temporary right ventricular assist device also. So RVAD we put, the patient got better. And now this is the situation that the patient is day 10. Patient is on VA ECMO also, and the patient is on LVAD also. Fine. Now, can you tell me the complications that can occur with VA ECMO?
Only VA ECMO or the VA ECMO plus assist device?
Wonderful. We will go them one by one.
Okay. Well, if we only have like VA ECMO, that means our oxygenation depends on the lungs. If this patient has pneumonia or cardiogenic pulmonary edema, then we have this north-south, so Harlequin syndrome. That's VA ECMO problems. So we have to make sure that it doesn't happen. We have bleeding and thrombosis, and if the LV bad, poorly pumping, then because we increase the afterload from the LV, the LV can get distended, and we have LV thrombus if the aortic valve doesn't open.
Wonderful. So you've actually named all of them. Although sometimes, as students do, we would like to classify these complications under few heads. Number of them being bleeding and thrombosis. And of course, when we are talking about bleeding and thrombosis, we don't want to miss out on heparin-induced thrombocytopenia.
Cytopenia, yeah, okay.
Yes, which actually manifests as thrombosis.
Yeah.
And of course, because these patients are on heparin and a constant risk of infection, they are at high chances of DIC.
Yeah.
Yeah, because these patients may have hepatic compromise also. All right. Then, of course, thromboembolism is a real risk in these patients because these patients are on bed until they can be moved about. And of course, the cardiac complications. So this is number one, bleeding and thrombosis. Number two is cardiac complications. So the cardiac complications are, number one, LV failure. So as you rightly said, LV afterload will be increased and there can be LV thrombus. Not only LV thrombus, there can be aortic thrombus also because of the same reason. All right, aortic root thrombosis as it is known as. Then the third head will be infections. So where all infections can occur? They can occur in the lungs, they can occur in the GI tract, and of course they can be line sepsis as well, cannula site infections. Because these patients are on stiff doses of anticoagulation, these patients are at a high risk of developing intracerebral bleeds as a neurological complication. And because these patients are at a risk of developing aortic and LV thrombus, these patients are at a paradoxical increased risk of ischemic strokes also. Of course, as you said, there can be chances of pump failure, the LV, and the limb ischemia is a reality. So we need a distal cannulation along with, and to prevent that limb ischemia. So these are the vascular complications that can occur with VA ECMO. So limb ischemia is one, and second is, as you said, Harlequin syndrome. Okay, so that is how you will, in a schema, you will mention the complications of, because it leaves out a good impression that you have the thorough understanding and you follow the trail. Then comes the LVAD and its complications. So again, can you tell me if you can make it out
bleeding?
in the headings? Yes,
bleeding, and then as a thrombosis and bleeding, infection from this from the wire they coming out, pump failure. Then probably RV failure under as a right ventricular failure under and then what else?
Arrhythmias.
Okay, arrhythmias. Okay, arrhythmias.
And very important with devices in the blood circulation, hemolysis.
Hemolysis. Okay. Yeah.
Okay. So rest of the symptoms like battery failure, controller failure, drive line damage, all of them can happen in these patients because of the paraphernalia involved in it. Fine. So LVAD complications are pump thrombosis, GI bleeding, infection, and drive line exit side infection, and of course, arrhythmia and right ventricular failure are the major complications. Okay, so this patient still is not having a good time. Day 7, the patient develops chest pain again. ECG shows ST segment elevation in anterior leads. The latest diagnosis is stent thrombosis. Now, my question to you is, day 7, it is, what is the best cardiac enzyme?
CK and CKMB.
Yes, so CKMB. Why not troponin T and troponin I?
Troponin E is must stay high. It stay high. Yes.
For 14 days, it stays high. So this patient developed a stent thrombosis. So this patient was on aspirin and clopidogrel. What is the next step? How are you going to manage stent thrombosis?
Go to the catheter for as a stent in stent, probably.
So take the patient to cath lab.
Yeah.
Open up the closed vessel.
Yes.
Do a thrombosuction. Open up the vessel. And once you've opened up the vessel,
Brilic.
Change.
Yeah, change the aspirin. Probably not aspirin Plavix, aspirin Brilic or plus other NOAC.
So aspirin plus Either ticagrelor.
Ticagrelor, yeah, Brilic or NOAC.
Not yet.
Not
but this
NOAC.
patient
Okay.
will be on heparin, right? This
Okay,
patient
yeah.
is already on heparin because he's on LVAD.
Yeah.
So you can give prasugrel.
Okay.
And you can also give this patient GP2B3A inhibitor. Hepfibitide, rofiban.
Yes. Yeah, for IV Agrastat. Yeah, okay, tirofiban. Okay.
So these patients, you take the patient to a cath lab, you open up the stent thrombosis, you shift the, you do a thrombosuction, you do balloon angioplasty, change the DABT to ticagrelor and aspirin, and of course, you may consider glycoprotein 2B3A inhibitor for potent platelet inhibition. Okay, so after a prolonged support on VA ECMO, the patient gradually gets better. He successfully weaned off the ECMO on day 10, but continues to be on LVAD and remains on dual antiplatelet therapy with ticagrelor and aspirin. Team is involved, cardiac surgeons are there, and then we are just managing this patient in the general room, floor room, and the patient is out of the critical care. And you manage the patient very well. Thank you.
Thank you.
All right. So this was the case, and now we'll take up few questions. Oh, this is from the previous class. Sorry. It is so similar patient had an acute anterior wall MI, late presentation. Day 3, the patient is in ICU. Patient was taken up for rescue PCI. Vessel was opened, but day 4, patient developed sudden onset breathlessness, required NIV, Lasix. Blood pressure is 140/80, heart rate is 120, and the patient is dyspneic. So this is the echocardiography finding. This is LV, this is LA. This is the color Doppler finding. And what is the diagnosis and how are you going to manage it?
This is acute severe mitral regurgitation.
Okay.
Probably due, yeah. And how to manage it?
So this is a papillary rupture, right? Okay.
Which anteroseptal you mean, or
No.
posteromedial?
Basically, acute severe MR due to papillary muscle rupture. Yeah.
Yeah. Okay. Probably anteroseptal papillary muscle rupture.
Rupture. Yeah.
Okay. Management is go to the send the patient to the cardiac surgeon, also cardiac surgery. Well, I think I probably try to negative fluid balance with diuretics, and I won't allow the patient to get bradycard. So because bradycardia is take a longer diastolic, and the mitral regurgitation will be worse. If patients start to develop a pulmonary edema, I go to the non-invasive ventilation. Lower the blood pressure. How? And how?
Yes.
We can use sodium nitroprusside, IV or nitro.
Okay. So, may I cut you short? So, one thing is we'll put the patient on NIV immediately. Number 1. Yes. This is what you do. Number 2, you give immediately diuretics. Again, Lasix 40 mg or 80 mg start, and then maybe 6 hourly or 8 hourly or even infusion. So that is it. Third, you have to have this patient on dilators. Some dilators, preferably nitrates, either nitroprusside or NTG.
Yes.
Plus, you need this patient to be on ACE inhibitors or ARNI. Never forget that. This patient needs ACE inhibitors or ARNI. ARNI, you know?
Yes, sartans, right?
ARNI is basically valsartan and sacubitril combination.
Yes, sartan. Okay.
Yeah. So that is ARNI. It is angiotensin receptor and neprilysin inhibitor.
Okay.
Or you have this patient on nitrates, ACE inhibitor, ARBs, and never forget ivabradine, which can be a very handy drug in case of heart failure. Why? Because you don't want to use beta blockers right now.
Yes.
Fourth is you can use milrinone in these patients because it is an inodilator. We need to decrease the SVR and whatever can come handy to us. Okay. And of course, going back to the case in discussion that we had in the CBS, you can put this patient on intra-aortic balloon pump. And of course, once the patient is on intra-aortic balloon pump, it serves as a bridge to
transplant,
to CTVS
surgery. Yeah, surgery.
So he can do a mitral valve repair or mitral valve replacement, either way. So the onus is to decrease the preload, diuretics, decrease the afterload by ACE inhibitor, ARBs, ARNI, hydralazine, nitrates, and intra-aortic balloon pump. This is where whole of the game is. So you manage the preload and afterload, you stabilize this patient, give it to the surgeon, do it what you want to do with this patient, either a repair or a replacement. Okay?
Okay.
Yeah. So the diagnosis is absolutely correct. The scheme of things that you need to proceed with is how you do this: NIV, diuretics, ACE inhibitor, ARBs, nitrates, hydralazine, maybe ivabradine, aortic balloon pump, surgeon, MR, MVR, or mitral valve ring repair. Okay, good. All right. This is another patient. Maybe this is one of our patients who came to us with complete heart block and RVMI.
RVMI, okay.
So this patient came with RVMI and complete heart block. So this patient was resuscitated in the ER with the help of a temporary pacemaker insertion. After some time, the patient became hypotensive. Chest X-ray was done. Do we have the X-ray here? No, sorry. I'll show you the X-ray. Let me find it first. Okay, so this is the X-ray. Can you see the X-ray?
Yes.
Yeah. Yes. This is the X-ray, and yeah, this is the CT. So, number one, what is the diagnosis? Number two, how are you going to manage
it? Pericardial effusion, probably it's a pericardial tamponade.
No. There is no tamponade. The right ventricle is absolutely fine. There is no tamponade.
Is this effusion? Pericardial effusion?
Yes, this is the pericardial effusion. Yeah.
Yeah.
So you define it as pericardial effusion, not amounting to tamponade.
Okay.
This is how you describe it. So there is a pericardial effusion, not amounting to tamponade. But you have to add the cause of it, right? Yes. So this is most likely a iatrogenic RV rupture.
Perforation.
Oh, sorry. So it is iatrogenic RV perforation. Although it can be rupture also because RV wall is so thin. Sometimes when it gets infarcted, it ruptures, but then it doesn't happen on the same day. So you put in this temporary wire, this TPI wire, it injured and perforated, and this is iatrogenic RV perforation, secondary to RVMI, and now leading to a pericardial effusion, not amounting to tamponade as of now. Okay.
Mhm.
So how will you manage managing this condition?
Um, IV fluids and
Very good.
ABC.
Yes. So IV fluids is the number one thing. You fill up the RV so much that
Yes.
it causes the tamponade of effusion. I mean,
Oh,
it compresses the effusion. Okay.
okay.
Yeah. So because anyways, the perforation is sealed with the help of temporary pacemaker lead. The
Mm-hmm. Yeah.
worst thing the residents do is to remove the temporary lead.
Oh, yes. Do not remove.
Do not remove it.
Yes.
Let
Yes.
the surgeon take care of it
Surgeon.
at a
Yeah.
later date.
Yeah.
So, and eventually all the rents they heal up spontaneously, because this patient will be required to be on antiplatelets and maybe anticoagulant. So there are chances that this rent does not heal properly. So keep the surgeon in loop and keep repeating the echocardiogram. Keep the echocardiogram by the bedside and keep
Mm-hmm.
monitoring this patient. Have an arterial line in situ so that you can have a real-time blood pressure monitoring with all the pulse. And
Mm-hmm.
because with the tamponade you will have some changes coming in the JVP waveform as well, so have a central venous line as well which is being monitored for CVP.
Yeah.
So
Okay.
and keep the CTVS team ready at all times, because this patient, if develops tamponade, the next thing that you can do is, while you are doing a serial echocardiography, if you find that the pleural effusion is growing up slowly, it's reached 2 centimeters. Reaching 2 centimeter is a good criteria for putting in a echocardiogram guided
Pericardiocentesis. Mm-hmm.
pericardiocentesis. You can
2 centimeters.
keep a this pericardial catheter there, and you can keep aspirating the blood as and when it is coming. So just relieving the pericardial space of any pressure will also help the healing. But
Mm-hmm.
the real test comes when you remove the temporary wire. If the
Yeah.
temporary wire is removed and the patient decompensates, having a cardiac team, CTVS team handy will be very, very effective, because then they'll open up the patient and do a pericardial patch repair. Is that
Yeah.
okay? Yeah.
Yes. Yes. Mm-hmm.
So this is the picture that you might get in the exam.
Mm-hmm.
All right. This is a young motorcyclist who was brought in the middle of the night to the hospital. He was unconscious and he was cyanosed. He was cold. This is the ECG that we did. Can you identify some problems in this ECG?
Mm. There is a ventricular so premature is this premature ventricle? No.
Are you
I think
sure? There is a
is this
P wave.
G wave?
J. Yeah, yeah.
J wave
Yes, yes, yes. What is it
and
known as? Another name? Good name?
Osborne wave.
Osborne wave. Wonderful.
Yes.
So what you see is an Osborne wave. Where is Osborne wave seen? In which condition?
Hypothermia. Hypothermia.
Hypothermia. Wonderful. So number one question is diagnosis, and the number two question is how will you manage this patient?
Diagnosis is probably hypothermia and managed with warming, passive and active warming. I think actively warming the patient.
Okay, so you replied very well. So basically, if I would have to, basically this is a Viva, right? Interview. So in this case, you have to classify the patient as having mild, moderate, or severe hypothermia. Only then you can decide how are you going to manage this patient. So mild is anywhere between 32 to above 32,
28.
right? Yeah. And moderate is 28 to
28 to
32.
32.
Severe is
Yes.
less than 28 degrees.
28. Yes.
So all you have is now to first you have classified. So mild, moderate, severe. For mild, all you do is passive heating. So how passive warming or rewarming? How you do passive rewarming? That is by using blankets, normal regular blankets, warm environments. But if it is a moderate hypothermia, do you do active rewarming? How do you do active rewarming? It is with the
Warm
help of
infusion, warming.
warm infusions, warm blankets, electrical blankets.
Yeah.
You can do a lavage also, peritoneal lavage with warm water, peritoneal lavage, or peritoneal dialysis with warm water, or you can do extracorporeal rewarming. That is with the help of dialysis machine only. But if the patient has severe hypothermia, then you will need aggressive rewarming of again with all these things included in that, but you'll have to go really aggressive intravenous fluids, and but it has to be a gradual rewarming even if you are going to do a severe hypothermia management. So this is Osborne wave, but then the crux of the matter is that you are managing a patient of hypothermia. Step number one is to classify them in mild, moderate to severe. Once you've done that, then you take a call as to how you are going to manage this hypothermia, which can be passive or active or invasive. All you need to do is first classify them. Okay?
Yes. Okay.
And what are the complications that can occur during rewarming?
Arrhythmia.
Arrhythmia and cardiac arrest. So when even if the cardiac arrest occurs and we say that it is good to have hypothermia at that time, still rewarming is important. You should continue rewarming even if the patient is in cardiac arrest, and give them defibrillations once the temperature has increased to more than 30 degrees. Because if you give the defibrillation earlier, it is just like a cardiac surgery when the patient has been put to a cold saline cardioplegia. So even if you give a defibrillation, it's not going to help. Okay, fine. All right. There are other questions. Okay. Because these are my actual routine things, no? So I have kept in the photo session. So, okay. This is a young lady, 30 years old. She was playing baseball. She had palpitations and she's been brought to the hospital. She feels dizzy, but the blood pressure is 110/70. Saturation is fine. What is the diagnosis and how are you going to manage it?
This is irregular rhythm. I think it's atrial fibrillation. Right? Or but atrial fibrillation.
So it is somewhere between atrial flutter and fibrillation. Okay. So
okay, yeah. Because I expect rhythmic also the same rhythmus in atrial flutter attack, I think.
Yeah. So atrial flutter is more regular.
Yes.
But atrial fibrillation is irregular.
Yes.
So this is atrial fibrillation with some bit of flutter waves you see here in V1.
Yes. Yes.
And a pretty regular stuff you see in V4, V5, you see pretty regular waves. So there are chances that this patient may have flutter fibrillation together.
Okay.
So yeah, in the long lead, you can see in the long rhythm strip, you can see that this is atrial fibrillation predominant. Okay. So how are you going to manage it?
The patient is stable. The patient is stable, right?
110/70. She is just feeling dizzy and palpitations.
Well, probably I get beta blockers or amiodarone. Okay.
So what is the role of beta blockers and what is the role of amiodarone? But before that, okay, so fine. So in this patient, you would like to treat this patient because she is young patient. She is just 28. She was playing baseball. She is 28 years old. Female, BP is 110/70, but she is distressed due to palpitations. Fine. So the step number one is to classify the patient. So this patient is hemodynamically stable.
Yes.
Atrial fibrillation. So you would try to give them medicines.
Yeah.
So medical management. So medical management, one is rhythm control.
Yeah.
The other is rate control.
Yes.
So if the patient is an old patient with LALV dilated, RARV dilated, you remember, okay, fine, this patient has a dilated LALV and I remember it from the last echocardiography, fine. All you need to do is control their rate to below 100. But if it is a young patient who has come to you for the first time with the uh, first episode of atrial fibrillation, you would want this patient to come back to a normal sinus rhythm.
Yes.
So how will you do that? So there is a pharmacological cardioversion, and of
Yes.
course there is a cardioversion,
Yeah.
DC cardioversion. So in the pharmacological cardioversion, you need to use 1B2A. So that means amiodarone or flecainide. Okay. So these are the drugs that you use for chemical cardioversion. Of course, DC cardioversion you will not offer to this patient. You can load them up with oral amiodarone and you can get the results. Fine. But if it is an elderly patient with similar picture, you would like to just control the rate. And how do you do that with the rate? You control them with BCD. So B is beta blocker, C is calcium channel blocker, D is digoxin. So these are why I want to tell you is because in the interview you may be asked, you mentioned beta blockers. Will beta blockers do the rightful thing in this patient? No. Beta blockers, what they will do at the most is they'll just control the heart rate. So to bring in the cardioversion, you need amiodarone or flecainide. Flecainide is so effective that it is also used as a PIP regime, that is pill in the pocket. So that means whenever the patient feels palpitation, they take flecainide oral.
Okay.
Fine. Okay. So whenever you are medically managing a patient of atrial fibrillation, the next thing apart from giving them medications to control rhythm or rate, what else do you give?
Anticoagulation.
So how do you give anticoagulants?
NOAC.
How?
Or oral anticoagulation with NOAC?
No, this is what you do. Chadvask.
Okay.
Yeah.
Yes, the score. So,
yes. So first you get the score. And if in a female it is more than 2 and in a male it is more than 1, then you give them anticoagulation. Yes, you are right. Oral anticoagulation, newer oral anticoagulation, NOACs are the drug of choice if it is a non-valvular atrial fibrillation. VKs still you will give if it is a valvular atrial fibrillation. Is that clear?
Yes.
So will you like to anticoagulate this patient?
Female is bigger than 2. Can I after I go after I give amiodarone, I can do the ECG, right? And if ECG is not in flutter or AFib anymore, probably not necessarily, or
so if the patient goes on to have atrial fibrillation for more than 48 hours,
yes, then I need to
then you need to anticoagulate them. If you decide to give them a delayed electrical cardioversion, like then you need to give anticoagulation for 4 weeks, 1 week prior to this DC cardioversion and 3 weeks after DC cardioversion. So that is actually an outpatient department based thing. But if the patient is in emergency and this patient has reverted back, then you do not need to give them any anticoagulation. She's just 28 years old.
Okay.
Yeah, and she doesn't have any comorbidities.
Do I need to give the anticoagulation like warfarin for 2 or 4 weeks, and then get the patient just as only to do the DC cardioversion, or can I just do the TEE and see whether or not there's a thrombus in the LA and then do the cardioversion?
So that is like after 1 week, if the patient is there and you are too skeptical to give them long-term anticoagulation, then yes, because before cardioversion, if it is only for 1 week and you have anticoagulated the patient from day 1, then there are less chances of having an LA thrombus. it is always good to go for a TE before you cardiovert the patient. That is a dictum. It is always good. But then if the patient is reluctant, they don't want it, it's okay with them, because you anticoagulated them on day 1.
Okay.
Yeah.
Okay, thank you.
Yeah, that is the normal question that you ask, that we face every day in the hospitals. Yeah. Okay, fine. So this patient is also a young 30-year-old male who was down with loose stools and vomitings for 2 days before he came to the emergency room feeling dizzy. The moment he drove himself to the emergency room, the moment he came out of the car, he collapsed on the floor. Picked him up, did an ECG, and this is what we have. He's conscious now, but then this is the ECG that he has. What is the diagnosis and how are you going to manage it? The patient has a history of loose stools, diarrhea, vomiting, and of course, low urine output for last 2 days.
It can be hyperkalemia.
Okay.
Because
what else?
We have
what else it can be? What else it can be? This is hyperkalemia.
Yes, I think it's what else as a differential diagnosis? You mean?
Yeah. What else? I don't see something as regular with P waves and everything to be presenting as. I mean, the first degree heart block is there. QRS is wide.
Peak high peak T wave, T wave, and the QRS is broad. As a broad QRS, and
it is nothing else but hyperkalemia.
Yes.
So what is the management?
The management is Lasix, also diuretics.
Just a second. You have one medication to give to save this patient's life. What will
one medication to give glucose insulin.
Glucose insulin
or inhalation, salbutamol inhalation.
Salbutamol inhalation will need ages to act. Something that will act like a jiffy, like this.
Like this.
Why do you forget calcium? Everybody forgets.
I see. I saw. Well, because calcium is only to metabolize, to stabilize the heart. It doesn't do anything about the kalium.
So this is what I'm saying. The patient has collapsed once. The patient came out of the car and crashed. Maybe he had a VT at that time. So you must know, if there is one thing that you would want to give to this patient, is not reassurance, is calcium.
Yeah. Okay.
Immediate calcium as a bolus, boof, in. And then you decide, okay, fine. Bring in the dextrose infusion with insulin. Bring in the nebulizer with Asthalin. Fine. Get it. Get a Lasix also. Fine. And this patient will be dehydrated and in pre-renal renal failure, he might need more fluids instead of Lasix.
Okay. Yes.
Okay. So this is the patient calcium. Of hyperkalemia. You gave calcium. See what happened.
Yeah, it's normalized.
It's normalized.
Yes.
So no more VT. Fine. No more torsades. You saved this patient. Everything else can come later. Immediately the antidote is calcium, IV calcium. Immediately give it. And then forget. And then the nurses can take care. Don't worry. You have done your job.
Okay.
Yeah. So this is hyperkalemia. Again, if you are into classifying like I am, so you would like to classify into mild, moderate, and severe. This patient unfortunately had moderate hyperkalemia, somewhere between 6.5 and 8. He has a high chances of going into ventricular fibrillation unless you act really fast. Okay?
Yeah, okay.
Fine. This is a 22-year-old man who's come to the emergency department after a high-speed motor vehicle accident. He was in the passenger seat and was wearing a seat belt. Now he tells you that I am having chest pain and I can feel breathing difficulty. The blood pressure is fine, 135/95. The pulse rate is slightly high at 105. Physical exam, patient is stable with a seat belt imprint on the chest. Anterior-posterior radiograph shows an obscured aortic knob. Preparations are made to get a contrast CT scan of the chest. And this is what you see on the chest. See what has gone wrong.
Aortic rupture. Is it a rupture or dissection? I'm not sure.
So it is a concealed aortic rupture. There's a aortic damage. Yeah. So possibly there is a dissection also. You can see it here. I'll have to shift it to books. Just a second. My pen won't work on the photo. Yeah. Okay. So you see, this is a dissection element here. This. You see a little bit of dissection here. You see a little bit of dissection here as well. So how do you manage? So this is traumatic aortic dissection or aortic concealed rupture. So what are you going to do is ABC.
Yes, ABC.
IV fluid.
Permissive hypotension, IV fluid.
Oh, wonderful. So the earlier candidate did not answer this. Thank you for mentioning it. Permissive hypotension with NTG or nitroprusside and calling the CTVS team to take care of things.
Yes.
Yeah. So everything ends with CTVS. It's better if there is a CTVS guy always there in the hospital. Fine. Okay. So this is another case of traumatic aortic. You see something very interesting here. I wanted to keep this patient as a question, but then the answers will be remaining the same. So this is a pseudoaneurysm of aortic descending aorta. Basically aortic arch only. It is post-traumatic.
Okay.
Can you see the aneurysm?
Yes. Yes. Yes.
Yeah. Okay. This is another patient who was brought intubated on ventilator by the paramedics when they recovered this patient by the roadside. He was hit. He was driving a bicycle, this motorcycle, and it hit a truck head-on collision, and he fell on the road. He was gasping when they saw him. They intubated him, resuscitated, and they've brought you this patient in the ER. The saturation is only 85% on 100% oxygen, and this is the CT that you see, and this is the X-ray that you see. Although you don't see an endotracheal tube here, but then this is the X-ray that you see. And this is the CT that you see. So give me the diagnosis and how are you going to manage it?
The diagnosis is probably a hematothorax. Is no, this is I remember.
No, this is no hemothorax. Where do you see hemothorax?
No.
That is why I give you the X-ray also.
Pulmonary contusion. Is this pulmonary contusion?
Yes. So this is traumatic lung contusion with ARDS because the saturation is 82% on 100% of oxygen. So how are you going to manage this patient?
A patient is already intubated.
Yes.
We have this ARDS protocol. Then I put the patient on a lung protective ventilation.
Define lung protective ventilation.
Yeah, low tidal volume.
Define low tidal volume.
6 milliliter per kg ideal body weight.
Okay. What else? Is that it?
And then I put the plateau pressure less than 30. The driving pressure less than 14 to 15.
Wonderful.
And then I try to titrate the PEEP according to the compliance. And if it's not working, if the PF ratio is bad still, I can do I can relax the patient as a muscle relaxation.
Wonderful. Very good.
And then proning the patient.
Okay, nothing worked. Nothing has worked. The patient is still unwell.
Also in proning position, patient is unwell. Then if the PF ratios are still under 100, then probably I go to the VV ECMO.
Wonderful. So that completes the answer. It ends at VV ECMO. Fine. Good. Same patient. His blood pressure is not coming up. What is this? This and this.
Liver and inferior vena cava.
Okay, so this is the inferior vena cava in inspiration, I mean on the inspiratory side, and then during the ventilatory expiration, this is the.
Okay.
During the ventilatory inspiration, this is the picture, and during ventilatory expiration, this is the picture. So, what is your diagnosis?
It's smaller on inspiration.
Ventilatory inspiration is smaller because ventilator is reverse.
Yes, yes, yes.
Okay, so the
yeah.
intrathoracic pressure is increased during inspiration in case of ventilation. In
Yeah,
normal
so
breathing, it is reverse. So
yes.
this is inspiratory, this is expiratory.
But how? I thought then it's so if inspiration on the ventilator, it's gonna be bigger
On
because we
ventilator,
have positive pressure.
yeah,
So
it is
this is the
having
expiration.
positive pressure, so it will collapse.
No, it's dilated.
So when you are breathing in,
If I
inspiratory.
breathing in, I collapse my IVC. But if I was put on the mechanical ventilator, then my IVC will get
Oh yeah,
dilated.
yeah, correct. So intrathoracic pressure rises, the venous congestion happens in the liver. Fine. So I spoke the reverse. So this is the inspiratory picture, and this is the again. I mean, it is the reverse. But then, what is the diagnosis?
Well,
So
probably the patient.
Inspiratory collapse.
Yeah, probably the patient need fluid. Also,
Is there anything else that you see? I can't draw here. Just a second. I'll have to go again to convert to PDF. Is there anything else you see here? Yeah. Here. Can you see something here? What is this? You want to erase it? So this is the anterior border of the liver, right?
yes.
This. What is this?
Intra-abdominal fluid. This is a free fluid.
Yes, there is a free fluid. Probably this patient has a hemoperitoneum.
Hemoperitoneum, yes.
So the patient has a expiratory or a collapse, respiratory collapse of the vena cava. So he needs more fluids, but at the same time he also has a free peritoneal fluid. You can see in this picture also. There's a lot of it.
Yes.
So this patient might have had a splenic rupture along. So you need to work this patient up for a CT abdomen. So that will come in the CT abdomen. You don't need a diagnostic peritoneal lavage these days. It is good to get a CT abdomen.
CTA.
Yeah. Okay. Fine. This is a patient on IABP.
Yes.
What is wrong with this picture?
It's late inflation problem.
Yeah. So this is a problem with the late inflation. So what will you do? How will you manage? The IABP should be inflated a little bit earlier. So you set the inflator to a little bit earlier, and also you do
T-wave.
and also you do a aspiration once. So you aspirate the balloon. Sometimes what happens is there is something stuck. So it is even after resetting it, this is troubleshooting basically. So it may be deflating a little late because there is a problem in the conduction of the pressure from the console to the balloon. Okay. We have another one. Just a second. It's there. Okay. Fine. Oh, given away. Just a second. Okay. So this is a young female, primi gravida, post LSCS, day 2. Patient developed breathlessness, collapsed. Code blue announced. Patient got intubated on. Now the patient CPR is going on, and this is the echo that you have done. What is the diagnosis? And what is the possible management steps that you can do?
I think this is a massive RV distension, probably RV failure. Is it an RV failure?
Why would it occur?
Because the RV is bigger than the LV.
Yeah. So what is it? What does
RV
this
failure,
mean?
acute cor pulmonale.
Acute cor pulmonale. What is the complication that you see in young primi gravidas post delivery?
Pulmonary embolism.
Wonderful. So this is pulmonary embolism. So what will you do? The patient is undergoing CPR.
Lysis, thrombolysis.
So the indication without getting a CT pulmonary angiogram for the thrombolysis is when the patient has collapsed and CPR is going on, and you cannot shift the patient for CT pulmonary angiogram, but there is a good evidence that there is a acute cor pulmonale and indicating a massive pulmonary embolism. So you can thrombolyze this patient. And what is the drug that you use in pulmonary thromboembolism thrombolysis?
Actilysis.
Actilysis is a brand name.
Teneclase and
that is again okay. So it is recombinant TPA.
Recombinant PP. Okay.
Yeah, RTPA basically. So you use that. So what is the dose?
Oh, the dose from alteplase. I don't know. I need to check.
So
I don't know.
So that is 100 milligrams of TPA. You give 10 milligrams as a bolus, and you give 90 milligrams over 2 hours. Okay, so that is how you give it. So 10 milligrams as bolus and 90 milligrams over 2 hours. So basically what happens is you have vials of 50 milligrams each. So you dissolve the 50 milligram in 50 ml saline. You give a 10 ml bolus, and then you give the rest of the 40 ml as an infusion at 40 ml per hour. Once that is finished, the next infusion is made in again 50 ml, and you give it at 50 ml per hour, and 2 hours are passed. And after 2 hours, you do a repeat echocardiogram. And at the end of the TPA, if the patient has no bleeding from anywhere else, you start the patient on low molecular weight heparin. And what is the dose for low molecular weight heparin? It is 1 milligram per kg body weight, given in 2 doses. That is, if it is a 60 kg female, you give 60 milligrams of enoxaparin 12 hourly, subcutaneously. And that has to continue for at least 7 days, because this patient had a massive PE. And then you shift on to this patient to oral anticoagulants. The guidelines favor rivaroxaban and this apixaban. So for apixaban, the dose is 10 milligrams twice daily for 7 days, and then 5 milligram twice daily. For rivaroxaban, it is good. You give 15 milligrams twice daily for 21 days, and then 20 milligram one daily dosing for at least 3 months to 1 year. So that is how you go from injectable to oral therapy.
Okay.
Yeah.
How the guidelines, is this enoxaparin, or is this just unfractionated heparin, and we do the PTT control?
So if it is, the guidelines say you can use either of them. Okay. With the unfractionated heparin, you need to do APTT and keep it twice. But if you are using low molecular weight heparin like enoxaparin or others are also there, but then if you're using a low molecular weight heparin, then you need to keep the 10A activity to double.
Okay. Yeah. Okay.
Okay.
Yes.
This is how you go for low molecular weight heparin.
Okay.
So, yeah. So these were the cases that I had kept for the CBS. If there is any particular question you might have, you can ask. Otherwise, I only have these ones.
Okay. Thank you very much, sir. This is very good. It's very good.
Yeah, I'm glad if you like the class. Yeah, that's good. So we can call it a day now. I hope the class was helpful to you, Dr. Stany.
Yes.
And I wish you all the luck for your EDIC exam.